So thank you very much, and let me start by congratulating the organizers. Only the organizers know what takes to get to this very point in which the whole meeting is now handled to the chairs of the seminars and the sessions, right? So congratulations to Guillermo and the crew, wherever they are. So the first presentation, as usual, deals with the burden of disease. And what I'm trying to give you now is sort of a feeling on the limitations that we have to say how many cancers occur in the world due to HPV. That doesn't work either. Hay que apuntar para allá. No? Can you discount that? Check. Hostia, pero esto es un lío. Es un lío. Take out head and neck. You can make the comment. Okay, so I found one that works, but I don't have a pointer, so. So this is a global estimate, right? The importance of HPV as a cause of cancer in the world. And then we want to say how many of these things happen. So when these estimates are based on what we know on cancer registration, they said 5% of all human cancers, 16% of cancer in women in developing countries. That is a phenomenal number, but still a number that, in my view, is uncertain. The components of the estimates are, you have to know what is your population, which in itself is a full science of demographics, trying to count how many women aged 15 to 65 live in Africa, for example. You need to have an estimate on cancer incidence, and that is only feasible in places where a great chunk of the population is covered by cancer registration. And then you have to link the two by sort of an attributable fraction and say how many of those are caused by alcohol, cigarette smoking, HPV, whatever. In terms of the population, that gives you a hint on how the world is distributed. You have on the one hand side developing countries where the vast majority of the population of the world live, and in the left hand side, the developed countries where you have this very peculiar format. But certainly it is very unevenly distributed. So in a cohort, for example, 10 to 14, which is typically a vaccination cohort, you have 36 million girls in developed countries, and you have 300 million in developing countries. I'll start giving you a feeling on the sort of burden of workload for vaccinating one cohort or another. And then by contrast, the vast majority of the cancer registration happens in the left-hand side, in the developed regions. And we do have very little on developing regions. with research is about the same. That'll give you an estimate on the population that is covered by cancer registration in various parts of the world. So in North America and Europe, we do have, say, 60, 70% of the population is under registration. But in Africa, it's only 1%. So uncertainties about how you multiply data from a 1% found in Dakar and few other major cities in Africa, and then multiplying by your expected number of women in that age range, makes it quite an uncertain thing. The second component, I don't know if you can read it, is that it is not only cancer registration, it is healthcare, in essence, because a registry can only register a woman that goes to a physician, the physician that knows how to diagnose cervical cancer takes a biopsy, the biopsy is being processed adequately, then it is registered, and then finally the registry sees it. So in a place where access to health care, high quality or at least average quality health care is not available, cancer registration is by definition underreporting, and global estimates that you start computing by multiplying by expected numbers, then makes it quite uncertain. So we are living very happily with the 500,000 women developing cervical cancer in the world every year. And my challenge now is to say, okay, it might be 1 million. It might be 1 million. And we are trying now methods to recalculate it backwards, right? So if you don't have diagnostics and registration, you do have surveys on HPV prevalence. And if you know that all of those are related, try to estimate how many cases would be in Africa based upon what we know on the prevalence of HPV-16 in a certain age range, right? But we haven't finished that work. So we'll be available in Vancouver or wherever we go next year. So you've seen this map before, and I'm not going to dwell onto that, but certainly when you distribute the incidence rate provided by cancer registration, you have like groups of clusters of countries at very high risk, intermediate risk, and low risk, and we are now living and having this meeting in one of the regions that is in the red side. All in all, cervical cancer, which is the #1 cancer in HPV-related stories, the current estimate is slightly above 500,000, with a quarter of them dying. Then it is important to realize that 85% of the burden is in developing countries. But moreover, in 42 countries, if I had the pointer, I would use it, but in 42 countries, cervical cancer is the #1, well ahead breast cancer. In 49 countries is the second, and in 16 out of 180 is the third. And if you look at young women before the age of 50, then cervical cancer is the second cancer, irrespective. It is in Europe, it is in the US, it is in Malaysia, it is in Malawi, right? So all in all, when you put cancer in women, we are still dealing with the second, if we only consider that. It is a cancer that strikes very early in life. Here you have developing and developed countries. And in the first graph, the yellow line, it is just a transition of the line in the developed part of the world, just to notice that in the very early age groups, the difference in incidence is substantial. And because it is substantial in the young women, what happened is that if you pair that with the mortality rate, and this is a sort of a survival rate estimate, and you notice that, for example, in the two African countries here, which is in the Gambia and Uganda, the two smaller dots in the right-hand side, survival rate, 5-year survival rate is in the 10 to 20%. So you've got a cancer that strikes very young women, that has a very high mortality rate. The distance between developed and developing countries is again substantial in terms of mortality. And therefore, the number of years lost to cervical cancer is huge. Here you have high-income, middle-income, and low-income countries. And the dark blue represents the fraction of the years of life lost that are due to cervical cancer. And you see that in the high-income countries is 5%, in the low and, is for me? No? So you better shut it up. So it's 22%, right? So again, a major piece of information that shapes where we have to put our preventive efforts. But then this is information that has been around for quite some time, and we are now expanding the number of cancers that are actually linked to HPV, most of which HPV-16. And you have the list here. It's cancer of, oh, thank you very much. Americans to the rescue, huh? Okay, so you have cancer of the vulva, the vagina, anal cancer, pharynx, oral cavity, larynx, and penis. So we start seeing a full array of cancers, both in males and females, related to HPV-16. But what we have for cervical cancer, which is essentially 100%, it is a much smaller fraction in all of them. So again, these fractions are the third component of my equation. What is the attributable fraction? So variability in those estimates are also relevant to compute the total number of cancers. So our gift to HPV 2012 are 2 new monographs, which are in your bag, if you are lucky. One just describing progress in the field, and a special one, which is not in your bag, but it will be shown somewhere, is a special report for Gavi countries. It just summarizes all we have in our information center on the importance of HPV-related cancers in Gavi countries. And we are now generating new pyramids like this one. Margaret Stanley opened the way in a recent publication looking at cases in Europe that were due to 4 HPV types and generated this graph with males and females, trying to show how the new information is expanding our vision on the number of cases related to HPV. So we've taken the model and generalized it to any HPV type, and this is an estimate for the world. And then we are now slightly above 600,000 with all the limitations we had. And that includes 11,000 cases of cancer of the penis, vulva and vagina, oropharyngeal cancers. And see, immediately you start perceiving that because oropharyngeal cancers have traditionally been cigarette and alcohol related, and it's a male predominant disease, as soon as you put a fraction on those related to HPV, then you start hitting significant numbers. Anal cancer, quite an interesting story on sexual behavior, about the same for males and females related to HPV-16. Cervical cancer still dominates, and then we have this huge burden of genital warts, which are difficult to estimate. In this case, it's 30 million. But again, if the difficulties with cancer registration are the ones that I mentioned, for diseases that do not have an adequate registration system like genital warts, then the uncertainty is still more significant. For the Americas, because we are in America and one always have to be nice to the host, see, the proportion of population in North America and South America that are covered by cancer registration is extremely different, right? So these estimates are largely due to the contribution of cancer registration in North America. But again, we have 2,000 cases, 5,000 cases of cancer of the vulva and the vagina, anal cancer in males and females, oropharyngeal, then cervical cancer, and these numbers in terms of genital warts that are largely based on 2 studies in the US and in Canada. Same thing for Europe. This is quite a reliable information. I'm not going to bother with the numbers now. These are available, and these should be available to you anytime if you need them. But I want to spend a couple of minutes with the Gavi countries. In here, the burden of cancers related to HPV is of paramount importance. And these countries, they only have an option, which is generalized immunization. So throughout the seminar, you will certainly be focusing on logistic aspects on how to vaccinate these more deprived countries in the world. Say, for example, if you put the ranking of cervical cancer incidence relative to other female cancers in Gavi countries, you see that it is the first one and most important one in a significant part of Africa, in the Indian subcontinent, in some parts in Latin America as well. And if you plot for these Gavi countries the incidence of cervical cancer, these are the Gavi countries, this is the world average, developing and developed countries, you see that the cervical cancer is perhaps one of the most dramatic examples of inequality on access to preventive medicine in the world. So just one last bit to complicate things a little bit further is that majority of the estimates that we are generating in terms of numbers are generated by estimates on the HPV DNA presence in the cancer. And that for cervical cancer, it worked very well. See, 100% were found HPV DNA positive. But then when you also use other markers like P16 or mRNA, trying to show that the presence of the virus is not only there, but it is also doing something. The virus is replicating, is interfering with cellular proteins and so on and so forth. So it's a further assessment of the etiological component. Then for cervical cancer, everything works well. And I must remind Mark that we haven't had any real failures in the field. So it worked very well. But then when you go to cancer of the penis, for example, 50% of those cancers, they do show HPV DNA, but only 60% of them show P16. And there's very, very many question marks in that column here. So to refine our estimates on the burden of disease linked to HPV, we now have this additional level of complexity, which is trying to show causality in a better way. And when you do that, our original pyramid, which is the brown one, with the numbers in here, if you just classify it or break it down by the ones of those that are, for example, P16 positive, you see that there is a reduction all over the place, right? Might not be very significant, but it adds to the quality of the information that we are giving. And that is particularly important for head and neck cancers. And just as an example, this is one of the latest of our studies that is now being prepared for publication. It's a study, a study that will include 4,000 cases of cancer of the oropharynx and oral cavity. And these are the prevalences of the HPV DNA that we found, right? Significantly lower than the ones that you might find in the literature. And this study, it does have centralized protocols for pathology and HPV testing and typing. Therefore, there has an internal consistency that the literature, when it's summarized, does not have. So if you compare it, for example, for oral cavity, that's what you find in the major reviews in the literature. This is what we found in our studies. For oropharynx, the prevalence is significantly different. And by doing that, we identified a number of variables that just are telling us that we should not extrapolate that mechanically from one part of the world to the next. So there is a significant variability by geography. So the prevalence of HPV DNA, for example, in oral cavity, is 1 to 20 if you compare Africa to Europe. So our estimates, when we move away from cervix, need to be qualified by this additional geographical variability. Certainly, there is another component, which is the age and period, as well as the cofactors that might be extremely different in certain parts of the world, right? So HPV DNA-related oropharyngeal cancers are much more common in younger generations than in equivalent age groups from previous generations, and so on and so forth. So that, again, it's another addition to the complexity. And for example, when we do that for Europe, and this is only part of our study, I don't know if you can read the numbers, but our estimates for oropharyngeal cancer related to HPV is in the range of 8,000. But when you consider the ones that do show HPV DNA, and in addition P16, you're going down to 3,000 or 3,700. And when you look at the mRNA, the 8,000 become 4,000. So there's still a significant amount of work to be done to finally tell the world which is the number of cancers in humans that are related to HPV. But we are working on that. So one final word, because I still have 2 minutes, on the types. Again, in the international surveys where we standardize and monitor the quality of each one of the steps, the pathology, the testing, the typing, and the statistical methods to deal, for example, with multiple infections in the same specimen, or low-risk types combined with high-risk types, and so on and so forth. This is the summary of the studies for cancer of the cervix. That's the contribution of HPV-16, the contribution of HPV-18, adding 10% of the etiological fraction, HPV-45 adding 6%, and as you move along the line, all the high-risk types, each individual one contributes a smaller and smaller fraction to the type distribution attribution. Here you have the cumulative proportion, and here you have the predicted number of cases, right? So if we consider that as the frame against which we will evaluate and predict the impact of our vaccines, a vaccine that would completely protect against 16 and 18 at the most would hit 70% of cervical cancers in the world. That's not bad, but it's 70%. If cross-protection against 45, 33, and 31 does fulfill the expectations in some of the studies, then we will move into a range between 75 and 85%, right? And if the new vaccine, including 9 HPV types, 7 of which high-risk types, it does show the quality of the response that we have seen with the quadrivalent vaccine, then will be in the 90% range, right? So keep that structure in mind, and against that, you should match the data for your country or your region. And again, a little homage to the region where we are, even if it's United States, it's very much part of Latin America. These are the countries in Latin America that contribute to this particular study, and here's the attributable fraction for HPV 16 and HPV 18, and you notice that the variability across countries is relatively minor. So again, an important public health message translating from the data, the vaccine should work equally well anywhere in the world where you use it. And I think that I will finish with that. Perhaps you might know what this image is. It looks like the tip of the cathedral from Gaudí in Barcelona, Spain, and that will be fine. But if you look at it in a little bit more of a detail, you'll notice that it is the highest monument to HPV ever constructed in the world. Thank you.